Good afternoon. Happy December, everyone. Welcome to our monthly Ask the Expert segment. My name is Erin Pellegrin. I am the Director of Culinary Nutrition and Education at Unite for Her. And each month, usually Sue and I bring you educational topics and segments relative to our Unite for Her community. And we are really, really excited to round out the year with a really important topic all about genetics and genetic testing. So we're really excited that you joined us this afternoon, and hopefully the hustle and bustle of the season hasn't been too much. But know that as with all of our educational segments, this is being recorded. So if you're not able to hop on live with us, or if you want to come back and rewatch this segment, it will be posted both on Facebook and on our Her Library. So again, I want to welcome you to our Ask the Experts segment. This is our Q&A style segment, which means that for those that are tuning in live on Facebook, you are also welcome to engage with myself and with our expert this month. So we are talking all about genetics and genetic testing, and we have one of the best in the industry with us to provide a little bit of clarification and instruction on genetic testing. Who should get it? When do we need to be retested? And provide a little bit of clarification, even in terms of guidelines and insurance and things like that. So a lot of information to cover this afternoon. Like I said, feel free to engage live with us on Facebook. So feel free to add your questions in the chat and we will get through as many of them as we can. We know a couple of you have submitted your questions ahead of time already, so we will be sure to answer those through our segment today. And like I said, this wraps our digital education for the year, but do not worry. We are coming in strong in January with our Plantuary initiative. So our culinary nutrition team will be sharing lots of different ways for all of our community to eat more plants. And we have our virtual hangout. We'll be doing a culinary activity. We'll be connecting with a dietitian from the American Institute of Cancer Research. So a lot of good stuff to come after the new year. So before we hop in, I want to, as we normally do, start our education events by thanking our sponsors, because without them, we would not be able to bring you these really important discussions and topics each month. So I want to give a big thanks to our presenting sponsor, West, with additional support from Daiichi Sankyo, Merck, Lilly, and GSK, because truly they really are our support each month to bring in, like I said, the best of the best in this industry to discuss important topics like genetics. So with that, I want to introduce our guest that we have today. So for those that may have viewed our segment last year, we were excited to bring back, like I said, one of the best in the industry. So Danielle McKenna is a board certified and licensed genetic counselor. And she spent 9 years working as a genetic counselor at the Vassar Center for BRCA at Penn Medicine. Recently, she transitioned to a new role as Deputy Director of Penn Center for Genomic Medicine to help improve the efficiency of genetic testing across all specialties at Penn. So it is truly my pleasure to welcome Danielle with us today. Thank you so much.
Hi, Erin. Thanks for having me. I'm excited to be here.
Yeah, we are really excited to have you back. I think the information that you provided with us before was just so thoughtful and clear. And it's like, you know what? It's always a good time to have these little reminders. So we're glad you're with us this afternoon. So I think to jump right in, a great place to start, Danielle, would be, let's start with the basics. So who should get genetic testing? Is it for everyone?
Yeah, so I'm going to go ahead and share my screen here where I put up the national guidelines of what of the people that they're recommending genetic testing for right now in 2023. And so right now, they're recommending that anyone who's had a breast cancer diagnosis at age 50 or under is eligible for genetic testing. All triple negative breast cancers, regardless of the age of diagnosis, all metastatic or advanced breast cancers, someone who's had multiple primary breast cancer. So this is a little bit different from a recurrence. This is when you have two totally separate breast cancers that developed independently. It's not that one breast cancer came back. It's two totally different breast cancers is what we mean there. And then anyone who has Ashkenazi Jewish or Eastern European Jewish background and who has breast cancer is eligible for genetic testing. And that's because we know that specific mutations in BRCA1 and BRCA2 are actually more common in individuals with that background. And so that's the reason for that particular criteria. And so those are the criteria for in an individual diagnosis. But then on the other side here, I have if you have a diagnosis plus a family history. So plus a family history of breast under 50, ovarian cancer, pancreatic, male breast cancer, metastatic prostate cancer, three diagnoses of those types of cancer in your family on the same side of the family. So it's gotten bigger as time's gone on. It's definitely more extensive than it's been previously. And so if you had genetic testing prior to 2013 and you were negative, you're probably due for updated testing. And that's because a lot of the technology changed around that time, and we discovered a lot of other genes outside of BRCA1 and BRCA2. So if it's been over 10 years, definitely time to come back and get some updated testing. And even if it's been within the last 5 years and you want to just double check, with a genetic counselor or your provider and say, this is what I had 5 years ago. Is this up to date, or do you think I need more? Is reasonable, because it really does change over time. So if you were negative in the past and you want to revisit it, totally reasonable. And then the last thing I'll say on this topic is that right now, it says if you're diagnosed breast cancer age 50 or under, that is the recommendation right now. There are a couple of expert groups that are pushing for that age to increase. So a couple of groups are saying it should really be anybody diagnosed age 65 or under. That is not the recommendation yet, but it's possible that maybe like next year that'll be the recommendation.
Wow.
So that would impact a lot of women with breast cancer. And so I think that's something to keep an ear out for. I imagine it'll be kind of in the headlines if that changes. And so there may be a lot more women qualifying for genetic testing in the next couple of years than previously who were.
Okay, that's really good to know. That we'll definitely be on the lookout for that. And going back to that last point, speaking to if you've had it more than 10 years, that 2013 timeline, even if you've had negative genetic testing. So that's to clarify, for someone that may have had genetic testing more than 10 years ago, had some sort of positive result, of course we'd want them to get retested. But even if there was negative testing before, all genetic testing was negative, it's best to go back and just re-up on that and see with new advances that have happened over the last decade. So whether or not a person was positive or negative for genetic testing, we want to make sure if it's been more than 10 years, they go back to see their provider.
Actually, I would say it's more for the negatives that we would want to repeat testing. So the positives, were unlikely to find anything new.
Okay.
That we didn't find 10 years ago. You could still ask your doctors about it, but it's really for the people where we have not yet been able to explain why you developed breast cancer. Those are the ones who should really come back.
Got it. Okay. Wonderful. Well, this slide is really, really helpful. And I know that, like I said, we'll be recording this, and we'll make sure to keep this slide with the recording presentation, because I think visually this is a really good learning tool for our community. So we appreciate you sharing that with us. So, you've talked about advances, which is a great thing, and we want to stay on top of advances. Research is so important. Talk to us a little bit about the accuracy overall. Like, has it gotten more accurate? How reliable is genetic testing in general?
Yeah, genetic testing is pretty reliable. Most labs quote about like 99.9% accurate. And so if there's a mutation there, we are most likely going to find it. It's just that occasionally there are mutations that are harder to find. And so sometimes a technology might miss it. But that's why they keep improving their technology over time to try and find all mutations. But in general, it's a very tiny percent of people who would have a false negative when they do genetic testing.
Okay, good. That's good to know. Wildly pretty accurate. So for someone that does have genetic testing, or maybe, they're an individual that goes back for retesting, if they tested positive, what do they do now? What are their next steps?
So There are actually about 20 different genes that we know of now in 2023 that are associated with hereditary causes of breast cancer, but they all have a slightly different risk profile associated with them. So some of them might be a high risk of breast cancer, some of them might be a more moderate risk of breast cancer, some might be associated with other cancer types like ovarian cancer risk, others might not be. It might be purely a breast cancer risk profile. And so it really depends on the different mutation that you have, but talking to someone who has experience counseling individuals with those types of mutations is what I would recommend most. So whether that be your oncologist, or maybe there's a high risk screening program where you are, or if there's a genetics provider where you are, that's probably the first place to go. There's not that many genetic counselors out there, so there's not always a genetic counselor at every location. So a high risk program usually has individuals who have seen other people with your mutations who can give you the most up-to-date guidelines and things like that.
Perfect. Okay. So we know where to go for some next steps. That's great. So we know that there's, different types of tumor testing. I think some of the words that we typically hear are germline versus somatic testing. Can you provide a little bit of clarification on what they mean? And even in the space of breast versus ovarian, what's the difference?
Yeah, this is a really confusing area for people because a lot of times their providers will use like genomic testing as an overall umbrella term for these things, which sounds like all the tests are really similar, but actually they're really different. And so you mentioned germline versus somatic testing. So germline testing refers to your inherited DNA, the DNA that you inherited from your parents that you can pass on to your children. So this is talking about things like BRCA1 and 2, things that would be increasing your risk of cancer that we can use to help lower your risk of cancer if we know it's there. Versus the purpose of somatic testing or tumor testing is they're looking at a tumor that's already developed to see what were the main drivers of that tumor and what can we target with a specific chemotherapy. So it's very different goals of the genetic testing. Tumor mutations are usually not inherited. They're usually things that just happen over time. So they're not things that you could pass on to your children, most likely. But there is a little bit of overlap. So if you find a BRCA mutation in the tumor, they might want to check your germline and make sure that it's not also there. But you have to kind of do both tests to get the complete picture if that's what you're concerned about.
Okay. And yeah, it absolutely does. And when someone goes for genetic testing, are they having both types of tests done?
That is really depending on where you are. So there are certain places that do both for every patient. There are certain places that do germline or the inherited for every patient. It really depends on where you are, what type of cancer you have. Ovarian cancer, they're probably going to get both. They're probably going to get both germline and somatic because that's the general recommendation there. Versus breast cancer, most women are not getting the tumor testing or the somatic testing. So it really kind of depends on different factors.
Okay. And why, let me ask you, so you just said most breast cancer patients are not getting somatic tumor genetic testing done. Why is that?
It has to do with the treatment options available. So with breast cancer, there's a lot of treatment options available that they try first before they have to go looking for like an alternative treatment, which they could get information from tumor testing about. Versus ovarian cancer, there's a particular type of drug called a PARP inhibitor that they like to give to certain people with ovarian cancer in the maintenance setting. That means after they finish their initial chemotherapy or radiation surgery, whatever the initial plan is, after that going forward, there's been a lot of research about treating ovarian cancer patients with PARP inhibitors if they have a BRCA mutation in their germline or their tumor, because regardless of where it is, they tend to respond to that. And so it's really the treatment options and the treatment plan that determines who's getting somatic testing.
Okay. And when that occurs, that's really the driver of it. Got it. That makes sense. Okay. Perfect. All right. So hopping to a question that we received from one of our members. So she sent in, what's the difference between breast cancer being hereditary or genetic? This particular individual was HER2 positive, hormone negative, and she has been told being HER2 is genetic. Is that true? And if so, what does that mean?
So all cancer is genetic in the sense that there was a mutation that occurred in your breast tissue in a gene that led to that cancer to develop. Some people inherit one of those mutations, which makes them more susceptible to develop breast cancer. Other people, that mutation occurs sporadically, randomly, it's not inherited. And so all cancer is genetic in that way, in that there's something in the cell that goes awry that leads to a cancer to develop. But not all cancer is inherited, meaning it's not always because you inherit one of those mutations from a parent. In fact, it's the minority of cancers that fall into that category. It's only about 5 to 10% of all cancers that we can truly say we have found the mutation that you inherited from your parent that caused that cancer to develop.
Got it.
So that's kind of the difference there. And then if you go back to the HER2 positivity, so all breast cancers are screened for estrogen, progesterone, and HER2. And these are different proteins that can be found in cancer tumors that they can target. This is, again, mostly about treatment. And so you might hear people say triple negative. That's when it's negative for estrogen, progesterone, and HER2. Triple positive is when they see all three of those proteins in a tumor. I wouldn't say that being HER2 positive means that it's an inherited cancer in any sort of way. It's actually the triple negatives that we tend to see more hereditary mutations in those group of women. So I wouldn't say that HER2 positive is particularly hereditary in any way. But yeah, so the reason that they're looking at those things is to figure out what type of treatment should we prescribe to that woman.
Got it. And I can see how just hearing that word genetic can be confusing because we may automatically assume that that means hereditary. So I appreciate the clarification there. Now, going back to germline testing, who should get that? Is that like an across the board, or are we sort of deferring to that slide that you showed to us earlier?
I would defer to that slide that we saw earlier. Now, if you have limited family history information, or you're adopted, or, there's some reason why we don't know the family history information, you can still ask about genetic testing. You can still get genetic testing. It's just a little bit less clear as to whether or not your insurance is going to pay for that, because they rely heavily on that criteria that I showed before. But most labs actually today in 2023 offer a self-pay price of about $250. So if your insurance says, no, we're not going to pay for this, a patient could still have it if they're okay to pay $250. Still cost prohibitive for people, but it's not as cost prohibitive as it was 10 years ago when it was $5,000 out of pocket.
Wow. And they could, so if someone, finds out that their insurance isn't covering it, they could essentially go to that same lab. They don't have to go to another lab and just pose the question, can I do a self-pay option? They wouldn't have to go anywhere special for their own individual testing.
Correct.
Excellent. Good. Okay. And you're right. I mean, that's quite a price drop. So if this is something that's really important to someone, still not cheap, but like you said, not $5,000. So it's good to know that option is there. Okay, so moving on a little bit to another term that I think often gets sort of jumbled in this conversation, which is oncotype testing. So what is that, and how does that sort of differ from the germline, the somatic testing that we've mentioned?
Yeah, and this is a really common area where patients get a little confused because they use, again, all these overlapping terms to refer to it. But oncotype testing is not germline testing. So this is not going to tell you if you have a BRCA mutation. This is not going to tell you if you have something you could pass on to your children. Oncotype testing is purely somatic or for the tumor. And they're seeing how aggressive the tumor looks to figure out whether or not that woman should have chemotherapy. So it's not even figuring out which type of chemotherapy should be prescribed. It's just, does this woman need chemotherapy or not?
Got it. So it's its own even like type or like its own sort of division off of somatic testing, essentially.
Exactly. Yep. It's its own
Okay.
category within that category, I would say. Yeah.
Yeah. Okay. And I hear often from our members, oncotype testing is pretty common in the initial diagnosis stage. Is that correct? Or is there a given population that might have that score, taken?
It's pretty common in the early diagnosis phase. I do think though, if you have purely DCIS or ductal carcinoma in situ where it's like stage 0, they're never going to consider giving that person chemotherapy, so they're probably not ordering Oncotype for that woman.
Got it.
But a lot of early stage breast cancers will have that done early on.
Okay. Good to know. So, we've talked a lot about the different terms that are part of genetic testing. For someone that wants to have a discussion with their physician, with their medical team, can you go over some of those important terms? Maybe we have our viewers grab a pen and pencil or paper and sort of write some of these down, but some of those terms that are important to know when they want to discuss having genetic testing done or with any sort of cancer diagnosis.
Yeah. So if you want germline testing, if you want to know if there's a risk of passing something on to your children, start with that. Because when you say that, doctors know exactly what you're talking about. They're going to send you to see a genetic counselor, or they're going to send off the germline testing. So if you say, I want to know if I could pass this on to my children, they're going to send you germline way. If you are interested in learning whether or not you're eligible for tumor testing, I think you could say, does it make sense to send my tumor for testing to see what chemotherapy to do? Or do I need any other testing to know if I need chemotherapy? But usually your oncologist is going to bring those up because it's totally about treatment. So if they're trying to figure out how to treat you, they're going to order those tests if they need them. So usually the patient doesn't have to advocate for themselves for that, but they might have to advocate for the germline testing. Like, hey, I know I have a strong family history. How do I get this done? Or I'm worried about passing this on. Can you refer me to a genetic counselor?
Love that. Okay, good clarification is important. So staying in the same realm of just arming our members with questions to ask and be prepared. When they're talking about their physician with the genetic testing or when they're going over their results, again, a lot of information, especially in the beginning, is often shared. I hear from our members a lot that there's just so much is being thrown at them. So what are some questions that we want to make sure they're asking their physician about their results, about what was done, so that they get a good understanding of, the information that they've received?
And this is specific to genetic testing?
Yes.
Okay. So one thing to know about genetic testing, and this is actually true of all genetic testing, but let's focus on the germline perspective. So germline genetic testing, they're reading through your genes like a book, and they're looking for a spelling mistake. If they see a spelling mistake, that is a positive result. We found something that's important for you. It's important for family members. We're going to talk a lot more about what it is that we found.
Okay.
A negative result means we looked at all the genes that we know of right now related to your cancer type, and we did not find a hereditary explanation or cause to that. The third type of result is called a variant of uncertain significance. And so that's when they're reading through your gene like a book and they see a tiny spelling difference, but it's probably not a big deal. It's probably totally normal for you. All humans have little tiny differences within our DNA that make us different, that aren't harmful. So it's a very tiny spelling change. We often use the example, if you think of the word gray, you can spell it with an EY or an AY. It means the same thing. That's what these are like. They're like very tiny differences that probably don't have a lot of impact on anything. So if you have a positive result, I'd be asking questions about who do I need to talk to about this? How can I get my family members tested? Which family member should be getting tested? Those kind of things. If you have a negative result, you could say, well, should my children still be doing any sort of increased screening anyway? Because sometimes even if you don't have a genetic mutation, if you have a strong family history of breast cancer, or you have a young diagnosis of breast cancer, like if you're diagnosed at age 45, they still might be recommending that your daughters specifically usually do different things. So maybe they start their mammograms younger, maybe they do breast MRIs. You know, there's things that we might be doing differently for children, even if we don't find a genetic mutation. And then so you can ask those same kind of questions if you have a variant of uncertain significance, because usually that's a negative result. So you can kind of ask the same questions that I just mentioned, but you can also ask, you know, well, how will I be notified if this changes? Because the lab will eventually reclassify a variant of uncertain significance, eventually tell you if it's positive or negative. So how will I be notified if it changes? You know, should I be contacting your program once a year to check in, those kind of things?
That's a great question. That's a great question. And I guess sort of as I'm thinking, you know, going back to what you talked about initially, if someone has had testing 10 years or more, right, before that 2013 timeframe, it is important that they have those initial results from that initial testing to do a compare and contrast. They don't necessarily have to go to the same testing center, I would imagine, but it's really important to have those previous results.
It is. It is. So if you have them handy, definitely bring them. If you don't have them, don't panic, because prior to 2013, there was one lab in the whole country that was offering BRCA1 and 2 testing. And so we know where to find it. So if you can't find it, don't panic. But if you do know where it is, it's helpful to bring. And anytime you have genetic testing, let's say you have genetic testing through one physician's office and then you go see a different breast surgeon, for example, really important to bring those results with you or make sure that the breast surgeon has it. We've seen, unfortunately, times where they have the testing on the outside, we don't get a copy, and then they were confusing oncotype and germline testing, right? So it's really helpful to always provide documentation of your genetic test results when you're seeing different providers.
Yeah, that makes sense. That makes sense. Okay. Jumping over to a question that was submitted from one of our members, is another question. So this person said, please talk about the ATM variant and cancers. She also asked about nutritional tips for reduction of mutations related to proteins. I'd be curious, you know, how you see that as a genetic counselor. And she read an older article that pointed out getting x-rays can make the mutation worse in pediatric patients. Has this been studied in adults? Can you speak to that at all?
Yeah. So in general, we consider ATM to be in the category of a moderate risk breast cancer gene. So if you have a mutation in ATM, your lifetime risk of developing a first breast cancer is probably in the range of 20 to 30, maybe a tiny bit higher than that, but 20 to 30%, as compared to BRCA, where the numbers are like 50 to 80%, right? So it's still higher than average, but it's not quite BRCA level. So that's why we call it moderate risk breast cancer gene. When you have one non-working copy of ATM, it is a moderate risk breast cancer gene. When you have two non-working copies of ATM, it causes a separate childhood onset condition called ataxia telangiectasia, which is a mouthful. So I'm just going to call it AT for short.
Okay.
Those people are not, we try and limit radiation whenever possible, because when you have two non-working copies of your ATM gene, we do limit radiation. But there's been several expert groups who have commented on having one non-working copy of ATM, which is the moderate risk breast cancer section, that it's okay to have x-rays. It's okay to have radiation for your cancer treatment if you need it. It's okay to go through security at the airport. So we're not having those same restrictions for ATM carriers, is technically what you would call them, but those are the men and women who have slightly increased risks of cancer. She probably was reading the article about the kids that have two non-working copies of ATM, which then we do avoid radiation, but it's different when you only have one.
Okay. And that typically, that one mutation, that moderate risk, would typically be found in an adult population.
Correct.
Okay. Okay. Perfect. Wonderful. Thank you. That's, yeah, really interesting. Genetics are so interesting. And you know, I'm sure you could talk, you do talk about it all day, but you know, just to hear about it
all day. Yeah. And back to her question about, proteins and nutrition. It's not something that I've ever heard, we see a lot of ATM carriers. I've never heard anybody in our group say, because of this, you should be on a particular diet. So I don't think there is a ton of research about a particular diet related to ATM, but if it's something that she wants to explore further, I think she could meet with a nutritionist or a dietitian and see if they can come up with a plan together that makes them feel comfortable with their diet.
Yeah, and I concur with that. Just doing my own research about this, there's not there's not good science to support that would be a nutritional indicator. But certainly, like you said, certainly working with our culinary nutrition team, we'd be happy to speak with this individual and sort of work with them. So you're right, they get to a point where they feel comfortable with the foods that they're choosing to include day to day, for sure.
Mm-hmm.
Another question that we had sent in from one of our members, both breast cancer tumors removed from her breast had neuroendocrine features present. Her grandmother died of pancreatic, so she wondered if it was possible that her DNA, given the history of her grandmother, may be contributing to the neuroendocrine feature presenting in her own breast. So is there any relationship between the two, possibly?
This is a really hard question, and she even put in her comment that there's not a lot of research, and I think that's the problem, is there's not a lot of research. In general, neuroendocrine tumors are kind of less hereditary than other types of tumors. So a lot of times when we see a neuroendocrine like lung cancer or colon cancer, usually those things we're not finding anything hereditary in neuroendocrine tumors. With breast and pancreatic both being neuroendocrine, it's definitely notable. It's definitely not something we see a lot of. And so I think she could definitely explore genetic testing and see if there's anything that we can explain that history with, but it's not classic for any of the genetic mutations that we're aware of, at least in 2023. So she's probably a good person. Explore genetic testing, and then if there's a research registry that she could participate in for families that have strong histories of cancer that we can't explain, she'd probably be a good person for a registry, but there's not going to be a registry, at least that I know of, for family histories of neuroendocrine.
Okay. Good to know. Great suggestions. What a a really specific, unique question, but hopefully there'll be more research to come for sure. So let's sort of jump over to, you mentioned this insurance and coverage, because unfortunately, that is a big driver of who may have genetic testing and who may not. So generally speaking, is it covered by insurance? And what sort of guidelines or recommendations, or again, maybe we're referring to that initial slide, do we need to be aware of in order to have coverage for genetic testing?
Yeah, so that slide are the national guidelines. So most insurance is out there are going to follow that as a baseline. There may be some that are a little bit more lenient. So there might be a insurance company out there that's going to be more accepting than the guidelines that I presented. But really what happens when you send your sample off for genetic testing is the labs that we use routinely do a pre-verification upfront. So most of the genetic testing labs will double check with your insurance before they run the test, and they're going to contact you if you have a particular out of pocket. A lot of labs use the cutoff of, if it's going to be more than $100, we're going to contact you and make sure that you're comfortable proceeding with the genetic testing. If it's 100 or less, most labs are just going to run the test. But the genetic testing companies are actually really helpful in helping you figure out if you're going to be covered or not. Genetic counselors can usually give you an idea of whether or not that's going to be covered. And then there's the $250 self-pay that you could always do if your insurance denies it. Just kind of in that realm, I will say 23andMe, those sorts of direct-to-consumer genetic tests that also cost about $200 are not going to provide you the same information about inherited risk of breast cancer as this testing that I'm talking about, the testing that a genetic counselor would order. It's very, very different testing, and we get a lot of questions about that from patients as well. Like, hey, I had negative 23andMe testing. Is that sufficient? It is
Yeah,
not. It is
yeah.
not.
That's a really great point because you're right. They do offer that. Like, do you want to have the additional BRCA testing? And so, yeah, that's a wonderful clarification because I'm sure a lot of people have that same thought.
Yeah. So basically 23andMe looks at like 3 mutations in BRCA1 and BRCA2, but there are thousands and thousands of different mutations that we've seen in BRCA1 and 2. So it's a really incomplete type of test.
Oof, okay. All right. Good to know. Not 23 and me. Okay. And then, not for this anyway.
Yeah.
Um, Now, okay, so finally, this has been a world of information. For those that are now interested in figuring out if their cancer center has a genetic counselor or if they just are looking to speak with someone, how do they find someone in their area if it's not part of their oncology center?
You can actually Google find a genetic counselor and it'll bring up the National Society of Genetic Counselors and you can put in your zip code and what
Mm-hmm.
area of expertise you're looking for, which in this situation you would hit cancer. And
Got
then
it.
it'll bring up a list of where are your nearest genetic counselors, especially post-COVID times. We have a lot more virtual offerings for genetic counseling as well. And so I think it's actually probably the most accessible time to find a genetic counselor than it's been in a long time because we have so many virtual options or telehealth options.
Yeah, that's so great. And also, you mentioned this earlier, a registry.
Mhm.
So is that also something that can be brought up if a person is interested in joining a registry just for future notifications they could learn a little bit more about through a genetic counselor as well?
Great question. Yeah, I think you could ask your genetic counselor if they're aware of any registries you would be eligible for. I know, for example, if you have a BRCA1 or 2 mutation, Vassar has a huge
Hmm.
registry, and I believe you can get more information on vassar.org if you're interested in participating in our registry. But there are different academic institutions have research
Their
registries.
own.
Yeah,
Got
Penn
it.
has one that's, anybody that has a strong family history of cancer, basically.
Yeah.
Um, and then there's plenty of other centers that have similar types of registries. So a genetic counselor is usually going to recommend that for you, but it never hurts to ask.
Got it. And it's good to know that's more likely through a medical center versus like a national registry that we might think of.
Yeah.
Okay. Wonderful. All right. Well, you've armed us with a lot of good information, a lot of good questions, and things to take with us, perhaps as our members chat with their medical team or just do a little bit more digging in terms of their own genetic testing if they should get it. So we really appreciate it. Any final thoughts, Danielle, on or anything you want to share with our community just moving forward? Anything they should know before we wrap today?
I would just say, I know it can be overwhelming sometimes to talk about and think about finding out if there's genetic risk of cancer in your family, but it's truly about preventing other cancers from happening. So we're not going to test you for anything that there's not a way to reduce that risk, right? There's always going to be a plan in place for something that we can do to help you if you have an increased risk of cancer. So we're always going to navigate with you through a positive result, which hopefully it makes people feel a little better about getting
Yeah.
genetic testing.
Yeah, yeah. To have that support in that sort of situation, I think is key. So having someone like you as part of their overall medical team, yeah, that support I think is worth its weight in gold for sure. Wonderful. Well, thank you. I mean, you're the best. Like I said, I mean, it was clear and informative, and we just appreciate you making this a little bit more understandable for our entire Unite for Her community. So we appreciate your time and spending it with us, during this really busy season. So thank you so much for being here with us.
Thank you, Erin. Thank you for having me.
You got it. All right, so that wraps our Ask the Experts for December. Like I said, we will be sharing this recording as well as the slide that Danielle showed in the beginning for our community. So take a look at that, share it with others that may find this information beneficial as well. And hopefully this, like I said, arms you with more information that you can take to have thoughtful discussion in the future if that is something you're interested in. So with that, I want to thank everyone for tuning in this afternoon. I also want to once again thank our sponsors for being such a big supporter of our entire digital education series. So big thanks to our presenting sponsor, West, and additional support from Daiichi Sankyo, Lilly, Merck, and GSK. We look forward to a very exciting 2024 with more experts and discussions and topics. But before we get there, we hope everyone has a wonderful holiday season, a safe holiday season, and we will see you next year. So everyone take care.